The subcommittee will come to order. The chair recognizes himself for an opening statement. Biologics are used to treat a number of serious diseases and conditions and have improved the lives of millions of Americans. They are produced from living cells using biotechnology and are often significantly more time-consuming and resource-intensive to consistently manufacture than small molecule chemical drugs. Due in large part to these complexities, biologics tend to be more expensive, and why the traditional generic approval pathway is not suited for bringing lower-cost alternatives to market. In 2009, this committee passed the Biologics Price Competition Innovation Act, BPCIA, by a vote of 47 to 11. Enacted in 2010, BPCIA established a new abbreviated pathway at FDA for biological products determined to be biosimilar to or potentially interchangeable with a previously approved reference product. FDA approved the first biosimilar in March 2015, is convening an advisory committee next week to consider a second application, and while there are close to 60 additional proposed biosimilar products enrolled in FDA's biosimilar development program, the agency has yet to issue guidance documents on several key policy issues that could have a significant impact on patient safety, prescriber decision-making, and market competition. I look forward to hearing from Dr. Woodcock about where these documents are in the review process, and would like to walk away from today's discussion with a better understanding of the agency's current thinking on issues such as naming, labeling, and interchangeability. Meanwhile, in preparation for biosimilars coming to market, the Centers for Medicare and Medicaid Services recently issued payment guidance related to Medicare Part B for biosimilars. Members will want to understand the implications of this broad payment policy and if it will account for variations and differences between biosimilar products, and moreover, what might that payment policy mean for the eventual growth in this market and innovation. With both witnesses here, we will be able to explore how could or should pending issues before FDA, for example, naming and interchangeability, impact the reimbursement policy under Medicare program, as well as access and affordability for beneficiaries. The committee will have an opportunity to hear directly from FDA and CMS on their progress with implementation of BPCIA and future outlook. I yield the balance of my time to Chairman Emeritus, Mr. Barton.
Thank you, Mr. Chairman, for holding the hearing, and thank you for holding it at 10:30, where I can actually be on time. I appreciate that. 6 years ago, I co-authored, along with Congresswoman Anna Eshoo, the Biologics Price Competition Innovation Act, commonly known as BPCIA, which, just as an aside, you'd have thought would have come up with a better name than something like that. Today, we sit as a subcommittee with numerous concerns about the implementation, or more appropriately, the lack thereof, of this important piece of legislation. Only one biosimilar has been approved. Numerous products are waiting to proceed through the approval process, and many physicians, patients, and concerned individuals like myself are concerned with the lack of progress. We all agree that it's important for FDA to get it right, but most of us think it's also time for FDA to get on down the road and decide exactly how to proceed with the approval process. There have been seemingly unending delays that are frustrating to legislators, innovators, doctors, and patients. I've sent letters to the FDA, the OMB, CMS, expressing these frustrations. I'm concerned that the CMS decision regarding reimbursement for biosimilars to be the average sales price for all biosimilars plus 6% of the reference product ASP, this approach undermines the real intent of the legislation. We want to foster a robust biosimilar market. CMS's approach eliminates any financial incentives in reimbursement for biosimilars by potentially forcing doctors and patients to use one non-interchangeable biosimilar in place of another based on price alone. This is detrimental because all biosimilars, as we all know, are not equal. By definition, they're not equal. I cannot overstate the importance of treating each biosimilar individually rather than as if they were a generic drug. I'm also concerned about the lack of FDA guidance regarding interchangeability in naming. Due to the absence of any such guidance, the FDA approved a biosimilar Xarexio with a placeholder name 6 years after the bipartisan bicameral BPCIA was signed into law. We're still waiting, and this is simply unacceptable. Thank you, Mr. Chairman.
Chair, thanks, gentlemen. Now recognize the ranking member of the subcommittee, Mr. Green, 5 minutes for his opening statement.
Thank you, Mr. Chairman. Before I start, I'd like to ask unanimous consent to place in the record a letter from the Biosimilars Council and ask unanimous consent.
Without objection, so ordered.
Thank you and good morning. Dr. Woodcock, welcome again. And Mr. Kavanaugh, thank you for being here. Today's hearing is the first we've had in the House of Representatives on biosimilars since the passage of the Biologics Price Competition and Innovation Act, or BPCIA, as part of the Affordable Care Act in 2010. It is particularly timely because the FDA is both developing the standards for approval of biosimilars and reviewing and acting on a growing number of applications for approval. At the same time, CMS recently released its final physician pay schedule, the PFS rule, which detailed the Medicare Part B payment of methodology for biosimilars. Determinations on biosimilars are approved, regulated, and reimbursed is critical to the success of this new and emerging market and must be in alignment to facilitate a robust, safe, and competitive marketplace. As we know, biologics play an important and growing role in our healthcare system. They arguably represent the future of therapeutics and hold immense promise to further transform the way we treat and prevent diseases. According to the RAND Corporation, worldwide sales of biologics were $46 billion in 2002, representing 11% of the global pharmaceutical market. Experts are predicting that by 2017, biologics are expected to grow to between $205 to $235 billion, representing approximately 20% of the global pharmaceutical marketplace. Recognizing the need for non-innovative biologics analogous to the generic drug market facilitated by Hatch-Waxman, and I worked with then Representative Tammy Baldwin and former Representative, now Governor Jay Inslee years ago to introduce a bill proposing a pathway for approval of biosimilars. Not long after, the BPCIA became law, paving the way for injection of competition into the biologic space. I know we all agree that competition is good for patient safety, consumer choice, and drives savings for consumers and the healthcare system at large. There are a number of outstanding issues on how these will be evaluated and treated by the FDA, including naming, interchangeability, labeling, and exploitation. The complexity of these issues are difficult to overstate, and I thank FDA for their ongoing efforts to develop policies on these questions. However, decisions on these major questions should not be made on a case-by-case basis, and it's time for the FDA to articulate clear guide rails and principles to industry and the public so that rules of the road are established and understood. Public and provider trust in the safety of biosimilars is vital to the success of this market. Acceptance of generics did not happen overnight. Only through a public, transparent process of developing guidelines and rulemaking will the public trust be earned. I look forward to hearing from FDA on the status of these policies and how the agency is moving these efforts forward. Recently, CMS detailed how biosimilars would be treated under Medicare Part B, and I have serious concerns about the final rule. While I appreciate the agency's desire to control costs, I fear that in this instance it would undermine this infant market and create a race to the bottom. If all biosimilars are on the same blended code, we actually disincentivize companies from investing in further trials for additional indications and would drive folks away from this market if we're trying to foster. Robust competition will ultimately realize the most sustainable, significant savings for the program and the best for patients. This rule seems in conflict with the efforts of the FDA to foster the biosimilars marketplace. I look forward to hearing from CMS and how this determination was made, responses to the concerns about potential undermining of the biosimilars market. And I thank you all for being here today, and I yield back the balance of my, well, does anybody want a minute on our side? Nope. Okay. I yield back my time, Mr. Chairman.
Thank you. And I'd like you to ask consent to submit the following documents for the record: statements from the Global Healthy Living Foundation and the National Association of Chain Drugstores. Without objection, so ordered. Chair now recognizes the Vice Chair of the full committee, Ms. Blackburn, 5 minutes for opening statement.
Thank you, Mr. Chairman, and I want to say welcome. We're delighted to have you all here. And we do have some questions about what is transpiring. And Dr. Woodcock, I want to come to you first. As you have heard from statements on both sides, we realize that this is essential, that the biosimilars are going to fill a place. It is an emerging component. But I want to go to one thing you said in your written testimony, and that is this: stakeholder confidence. I know that.
Oh, this is a statement?
Stakeholder confidence is essential to the success of the biosimilar program. And this is something I'm going to come back to you on. When I talk to innovators that are in Tennessee, what they're confused about is the lack of certainty. The chairman mentioned to you about the documents and the lack of guidance, where you all are in this process. So the hearing today is important because of that. These innovators are looking to get some certainty. These are complex decisions. We appreciate that. We know that this is a new class of medicines, and that brings me to my second point. Mr. Kavanaugh, I'll discuss this with you as we move forward with the hearing. Looking at the realization, biosimilars and generics are not the same thing. And we want to be certain that you all are addressing this in the appropriate manner. We appreciate your written testimonies. We look forward to digging down with you on some questions and maybe some things that we're going to request for a written answer. And Mr. Shimkus, I'm going to yield the balance of the time to you.
You are so kind. Thank you. Because I want to make sure that we submit for the record with Mr. Chairman. I have 2 surveys, both by for the Alliance for Safe Biological Medicines, and one's a physician survey, one's a pharmacist survey. You know, if our goal is to ensure access to these products into the marketplace, shouldn't we enact a transparent labeling policy that creates confidence in the healthcare market? So if you would share these with the minority and accept these, I would, for the record, I would appreciate it. And that's all I have. Thank you.
Is this all right?
Hello, have we agreed to? We haven't sent them yet? Well, I'm sure we will, but let us.
All right, they'll take a look at them. We'll come back to that. Chair now recognizes the ranking member, Mr. Plone, 5 minutes for opening statement.
Thank you, Mr. Chairman. I want to thank you for holding this hearing and also thank Dr. Woodcock and Director Kavanaugh for being here to discuss the implementation of the Biologics Price Competition and Innovation Act. Biosimilars hold enormous potential to offer patients with serious and life-threatening diseases access to more treatment options and potentially lower cost options. And I look forward to hearing your testimony today about how FDA and CMS are working to establish a clear pathway for approval as well as an appropriate reimbursement structure. These are both critical elements to ensuring the success of this market. The use and sale of biologics continues to rise here in the United States and elsewhere. By 2017, sales of biologics are estimated to be between $205 and $235 billion, approximately 20% of the global pharmaceutical marketplace. And this is why encouraging and facilitating competition is so critical. While biosimilars have been available in Europe for some time, Congress did not establish an abbreviated pathway here in the U.S. until the passage of the Act as a part of the Affordable Care Act in 2010. And I supported the creation of a pathway for biosimilars and for empowering FDA with the authority and resources to ensure that biosimilars are safely available here in the United States for the patients that need them most. I was pleased when FDA approved the first biosimilar, Zarxio, in March 2015, and this action demonstrated that the approval process is working, but I've also heard that greater clarity is needed from the FDA. Since 2012, FDA has issued important guidance meant to inform industry sponsors as they consider developing biosimilar products, including scientific and quality considerations. Additional guidance is still needed, though, particularly in the areas of developing and marketing biosimilars. Guidance on interchangeability, labeling, and naming are still outstanding, and FDA's thinking in this area will be vital to companies looking to enter the biosimilars market. We've seen how our healthcare system has benefited from the competition that comes with a robust market. Competition has helped to lower healthcare costs for small molecule drugs, saving the U.S. health system $254 billion in 2014. And it's my hope that we continue to do all we can to lay the foundation for these types of savings. Our federal health programs will also play a large role. CMS has the ability through both Medicare and Medicaid to encourage this new marketplace, and that's why I was concerned that CMS finalized its Part B payment policy for biosimilars last year, combining all biosimilars into one average sale price calculation and payment code. I worry that this inappropriately treats biosimilars like generic drugs and will disincentivize manufacturers from entering the biosimilars marketplace, because biosimilars are not generics. Each is its own unique product, and biosimilars go through a much more stringent approval process. In fact, Medicare Part D and Medicaid both acknowledge this in their respective programs. This marketplace is only just emerging, with only one approved biosimilar, so it's important that we hear from both FDA and CMS not only about what they're doing in this space, but how they're coordinating to ensure that the biosimilar marketplace is both safe and robust. I just wanted to add one thing. I think all of you know that the issue of drug pricing continues to rise in terms of the concerns of the American public. Our Democratic Steering and Policy Committee actually had a hearing on drug pricing, and at that hearing I was concerned to hear, I think I asked a question about generics, and I was told by the witnesses there that generics increasingly are not a way of reducing prices because of the changes that are occurring in the marketplace. And so I do worry that it's important in the case of biosimilars or generics that continue to be a way of reducing drug pricing. If it isn't, then we're going to have even more of an outcry that prices are too high, and that there should be some kind of intervention by Congress or by the federal government in the marketplace. So I think that this is an issue, even though we're talking about biosimilars today, Mr. Chairman, this is part of the larger issue of Americans being very concerned about drug pricing, and of course it's entered into the presidential sweepstakes or whatever as well. So, this is an important hearing, not only in terms of what's happening to biosimilars, but just the larger issue of drug pricing. Thank you, Mr. Chairman.
Chair, thanks, gentlemen. That concludes the prepared opening statements. As usual, all members' written opening statements will be made a part of the record. We have, without objection, the two documents that Mr. Shimkus asked to enter the record are ordered to be entered into the record. We have one panel today. On our panel, we have Dr. Janet Woodcock, Director, Center for Drug Evaluation Research, Food and Drug Administration, and Sean Kavanaugh, Deputy Administrator and Director, Centers for Medicare and Medicaid Services. Thank you very much for coming today. Your written testimony will be made a part of the record. You'll each have 5 minutes to summarize your written testimony. And Dr. Woodcock, you're recognized first for 5 minutes.
Thank you, Mr. Chairman and members, for allowing me to be here today and testify. Biological products are used to treat patients who have serious and life-threatening medical conditions such as rheumatoid arthritis, cancer, serious gastrointestinal diseases, and so forth. It's important for the health of the public to have access to safe, effective, and affordable biological products. Biosimilars can provide more treatment options to patients and possibly lower treatment costs, resulting in better access. FDA in general, and I personally, have long supported getting the availability of a biosimilar pathway, and we were very pleased when Congress enacted this pathway. I've been involved in development of biological therapeutics myself for about 30 years, and I've seen the transformation they have caused in healthcare in some areas. I'm a rheumatologist, and the biologics have totally changed the face of rheumatology. We used to have patients in wheelchairs lined up in our clinics, and we're talking about joint replacements, we were talking about nursing care, and so forth, nursing home care. And now, instead of talking about that, we talk about treating to remission, how to make the disease go away, how to make those folks function like as if they weren't sick. It's been a miraculous transformation. But this needs to be accessible to all Americans, not inaccessible to some because of cost. Since the biosimilars pathway was created in 2010, we've actually seen a lot of progress. Now, much of this progress is under the hood, so to speak, because the law required that the biosimilar drugs be found biosimilar to a reference U.S. product, which meant that they had to study it to the products that were on the U.S. market, and that takes an amount of time. But we did approve the first biosimilar in 2015. We have an advisory committee coming up next week for another biosimilar for the advisory committee to consider. And there are almost 60 programs under development in various stages that we have talked to us. And we know of perhaps several dozen others where they've reached out to us but haven't engaged in our process. But I know people are anxious to see more progress and more certainty. I do understand that about the pathway. Now, if you look at small molecule generics, as we just said, they've been very successful. Over 88% of dispensed prescriptions in the U.S. are generic drugs. And actually, they are continuing to save a lot of money. There are a small number of products do not have generic competition still, and those they may have price increases. But this has been a very successful program, the generic program. But if we compare it, we did not have success overnight in that program. It took a while to establish the parameters, to get the industry to the state they need to be, and to get acceptance of the clinical community. So I think maturity of the industry and gaining confidence of the healthcare community was really critical to this 88% of dispensed prescriptions being generics. To earn and to sustain both physician and patient's confidence in biosimilars and interchangeable products, we must apply a scientifically rigorous review process and approval standard that people believe in and trust, because these products have been life-changing for many people, and they don't want to sacrifice any performance. And we don't intend that they would sacrifice any performance if they take a biosimilar. Although the first biosimilar is now marketed, there are a lot of legal, technical, and policy challenges ahead. Some of them you have raised about various policy issues that must be resolved. We fully recognize that and intend to do it, but I will assure you there's a bright future ahead for our biosimilars program, and I believe it's going to provide the same access to important medications that our current generics program is doing, and really benefit the health of the public. I'm happy to answer questions.
Chair, thanks, gentlelady. Now I recognize Mr. Kavanaugh, 5 minutes for your summary.
Thank you, Mr. Chairman and members of the subcommittee. I appreciate you inviting me here today to talk about Medicare Part B payment policy for biosimilars. As you know, the Affordable Care Act created an abbreviated pathway for approval of biosimilars by the FDA, and it created a provision for the establishment of Medicare payment policies for these products. Biosimilars hold great promise for all Americans, including Medicare beneficiaries, and we're committed to policies that will provide fair payment in a healthy marketplace. In 2014, Medicare Part B spent $21.5 billion on prescription drugs, with the top 15 products accounting for $11.5 billion of this total. 11 of those 15 products were biologics, and the top 6 products were all biologics, and each one of those contributed over $1 billion in spending. CMS has an obligation to make sure taxpayers' dollars are used responsibly. This includes creating good payment policy and making appropriate coverage decisions that provide access to innovative services and treatments while incentivizing the use of treatments and delivery models that are efficient. When the first biosimilar entered the market last year, we quickly assigned a billing code to facilitate Medicare beneficiaries' access to this new therapy, and we began an outreach process to the provider community to make sure we could share with them guidance on how to submit claims for the new biosimilar product. Also, as several of you noted, last year in our annual physician fee schedule rulemaking, we proposed and finalized a policy that promotes fair payment in a healthy marketplace. It was important that we implement a Medicare payment policy for biosimilars now, before the second biosimilar for any reference product becomes available, to provide certainty for providers and suppliers who will be billing Medicare for these products in the near term. The statute provides for payment for biosimilar products in the same manner as the statutory methodology for multi-source drugs, where more than one drug product is included in the same billing code. We're confident that our interpretation of the law is sound, and it represents good policy that will facilitate innovation and competition in the market. We implemented this new policy through our normal rulemaking process. We solicited, thoroughly reviewed, responded to, and in some cases modified our proposed policy based on comments from the public. For example, in collaboration with our colleagues at the FDA and in response to public comments, we implemented a requirement for claims for biosimilars to include a modifier that identifies the manufacturer of the specific product. We recently published guidance on the use of this modifier on our website. This will allow us and others to track which specific biosimilars a beneficiary receives. Overall, the availability of generic drugs in competition with each other and with branded products has improved price and availability of drugs. Competition among biosimilars can do the same for Medicare beneficiaries. Like multiple source drugs, CMS sees biosimilars competing for market share with each other as well as competing with the reference product. Encouraging this competition reflects a top priority at CMS. The field of biosimilars holds great promise for future improvements in health, value, and outcomes. We believe patients, manufacturers, providers, insurers, and government all share a common goal to foster a healthcare system that leads in innovation, delivers affordable, high-quality medicines, and results in healthier people. CMS policies will continue to ensure Medicare beneficiaries have access to biosimilars and other innovative treatments. As more biosimilars are approved, we'll monitor developments in the market and consider refinements to our policy as needed based on experience with this new segment of the market. We look forward to continuing to work with this committee to gathering information from providers, suppliers, and other stakeholders to better inform our guidance and regulations in the future. Thank you, and I'm happy and look forward to your questions.
Chair, thanks to the gentleman. Thank you for your opening statements. I'll begin the questioning and recognize myself 5 minutes for that purpose. Dr. Woodcock and Mr. Kavanaugh, can you please explain how your two agencies have been coordinating on implementation efforts and discussing policies that could impact each of your agency's decisions? Dr. Woodcock.
Yes, we work very closely together on those matters where our jurisdictions may interact with one another or where their impact. We certainly have had long conversations about the need for safety tracking of these products, and I think CMS was very helpful to us in enabling this identifier so that claims data will have some sort of identification so that we can track these products that are paid by Medicare. We've worked together on numerous activities where needed, but generally we're on a scientific track and they're taking care of beneficiaries.
Yeah, I would add to that as the FDA has worked through its processes on the naming convention for biosimilars, they've repeatedly kept us in the loop to make sure we understood what was going on, solicited comments. We actually don't take a position on the naming convention, but they've been generous in their consultation. This really, in biosimilars, our collaboration really builds on a legacy of work. We collaborate in the regulation of lab safety. We recently implemented a process of parallel review when the FDA is approving products and we can do a coverage decision for Medicare at the same time. So I'm sure there are improvements, but there's a history here of working together and a commitment to continuing that.
Has FDA ever sat down with CMS to walk through the many fundamental differences between biosimilars and generic drugs?
Yes. members, medical staff at CMS are very well aware of all these and have been privy to many of our discussions about them.
Dr. Woodcock, FDA has spent several years now grappling with policy decisions on how a biosimilar should be named and labeled in relations to its reference product, particularly if it is approved for different indications and if there are other biosimilars for the same disease or condition. Are you concerned that these nuanced decisions could be undermined by CMS's decision to lump them all together for coverage and reimbursement purposes like they were generic drugs?
Well, the being able to track for purposes of safety and attributability is different than the payment. So the issue of tracking has been resolved by what CMS has done with the modifiers, and I'm not competent to talk about how reimbursement is arranged.
Mr. Kavanaugh, in its draft naming guidance, FDA seems to make the case that distinguishing biosimilars from their reference product and other biosimilars is critical to patient safety. If this is the case, why did CMS not share this view and take the opportunity to have different billing codes?
Well, as Dr. Woodcock said, they have been very generous in their time helping us make sure we understand completely the clinical and therapeutic distinctions between generics and biosimilars. What CMS has put policy out, though, is on payment and coding, and physicians don't typically look to billing codes in order to understand which product they're ordering. It's a very different process. So as Dr. Woodcock suggested, and I would agree with, there's really no disagreement here and no conflict in that the payment policy, which has to be informed by the clinical, but it doesn't have to be entirely reflective of clinical distinctions.
Well, combining all products into one code inherently removes some incentive for biosimilar companies to develop data on specific indications or seek interchangeability. Did CMS consider these impacts on innovation?
We did. I mean, the purpose of our policy was to spur innovation, and we believe it will do that. You know, the fact that there are multiple products under the same billing code in the generic market has not, I think, depleted innovation or competition. In fact, the history of the generic market is robust competition and a lot of products being developed, not immediately, as Dr. Woodcock said, but we think it's a sound policy, and we think it will spur innovation and not hinder it.
Thank you, Chair. Now I recognize the gentleman, Mr. Plone, 5 minutes for questions.
Thank you, Mr. Chairman. I wanted to ask Dr. Woodcock some questions. FDA has been criticized for not being transparent in the development and implementation of the BPCIA. FDA has also been criticized for not releasing guidances more quickly and not doing enough to educate patients and healthcare professionals. Obviously, these critiques are significant given what the BPCIA is enacted in 2010. I guess we had an estimate from the Congressional Budget Office of a $7 billion savings in the first 10 years, okay? So a lot is at stake. And of course, I talked earlier about the whole issue of drug pricing, you know, being sort of a national priority right now. So how much money did Congress appropriate for the program that has the potential to provide so much savings? And will the funding FDA has received from Congress and industry be sufficient to keep up with the growing interest in the development of biosimilars?
Congress did not appropriate any additional funding for us to do the biosimilar program.
I didn't hear you, Dr. Woodcock.
Congress did not appropriate any additional funding for the biosimilar program.
Okay.
When the user fee program, they put in place the ability 2 years later for us to enact a user fee program. When that user fee program was put into place, it was stipulated that we take $20 million out of our existing BA budget and put it into the base. But that was not additional funds. That was funds we had to take from other activities such as OTC monographs, compliance activities, and so forth. And of course, when we put the user fee program into place, there really wasn't an existing market, unlike the
Right.
prescription drug user fee or the PDUFA. or GDUFA, and so we couldn't bill an industry that didn't exist. So we put in place a staggered fee structure for development meetings that we've been enacting, and we have collected monies from that to help build the program. But of course, that has been only in the latter parts of the program.
Well, then I guess, the larger question, which I'm trying to get at, is to what extent is that, this funding or lack of funding not working and making it more difficult in terms of, having a backlog of applications, increasing review timelines, and contributing in some way to some of the criticism. And what do you need, or what do you suggest we do so that, you have enough money?
We have begun to collect more monies under the user fee program. In FY13, we finally collected $6 million. So that was the extent of the program. In fiscal year 14, we collected $13 million, and last year, FY15, $23 million, $23.8 million. So we are beginning to build, and as drugs get on the market, biosimilar drugs will be able to have a different, perhaps more robust funding for this program. But this program was not funded by appropriations.
Okay, but I guess what I want to ask, and I don't have a lot of time, specifically, to what extent, because you don't have this money, is that contributing to the backlog, the not releasing guidance, not having enough education, development implementation of the program? And what do you suggest we do in order, we're getting all these criticisms, and it sounds to me, although you haven't said so, that part of it is a lack of funding.
Well, what has been is water under the bridge. Going forward, we do expect to release drafts or many finals of these guidances in this current year, this coming year. So hopefully some of these criticisms will be addressed, although these are controversial issues. Clearly, had we had more staffing and funding at the get-go, and we could have set up a program in 2010, that we would have been better off now. However, what I'm concerned about is that this program is going to explode, that we are seeing multiple entries potentially for many of the existing biosimilars, those top 6 or 11 or whatever. Naturally, there are people who'd like to have a part of that market or compete into that market. And I'm concerned that we will not have the staff because we're always waiting to catch up.
All right, well, this sounds, because I've got 3 seconds left, sounds to me like you need some kind of appropriation, and that, this having the industry pay a fee is not good enough. But I guess you're not going to tell me you need the appropriation.
I can't comment on that.
I know you can't, but that's what it sounds like. Thanks.
All right, gentlemen's time's expired. Chair now recognizes the Chair Emeritus of the full committee, Mr. Barton. 5 minutes question.
Thank you, Mr. Chairman. And I wish that Congresswoman Eshoo was a member of the subcommittee, because while I know a little bit about this, Anna is really the expert on this issue. She and I are the authors of the bill that got put into the Affordable Care Act on biosimilars. It looks to me like we have 2 issues here. We have an FDA issue. Let me get where I can see Ms. Woodcock. We have an FDA issue about how to approve them, and then we have a CMS issue on how to charge for them. If you don't get the approval process right, it doesn't matter what you charge for them, because there's nothing to be used. But if we can get the approval process right, it doesn't matter unless we get the reimbursement process right, because if you set a reimbursement process that there's no incentive to create the drug in the first place, the biosimilar, nobody's going to do it. And on the approval, I would give the FDA a C+, maybe a B-. I think your heart's in the right place. I know you, ma'am, based on my interchanges with you in the past, plus what you said in your opening statement, you want to get it right and you want to get it done. With regard to CMS, I'd give you a D-. The only reason I won't give you an F is because at least you're trying. You've got something out there. And I guess go back to the FDA, we need some labeling guidance. The first biosimilar, Mrs. Woodcock, that the FDA's approved, the labeling is just not as complete as it should be, as transparent as it should be. Could you comment on that? Does your agency plan to address the labeling issue and try to
Yes.
to get it better?
We do plan to issue draft guidance. We've had many opinions on how the label should be. We've received much input from stakeholders, and that's one of the guidances that we would like to get out this year as a draft.
So to clarify, you do plan on changing that specific label?
Well, we'll issue a draft, and then we need to issue a final and get a policy together, and then the labels will conform. All labels would conform to that. If you recall, the statute that was enacted was considered to be self-implementing, as I understand, without guidance.
But you still have to do it.
Well, we are approving, as they become available, we will approve biosimilars regardless whether we have final guidance out or not. That does create more ambiguity. And so perhaps the language in the statute that considered it was a self-implementing program was a little optimistic in the sense
That's true.
that
I'll accept that.
there were a lot of policy issues that we needed much more detailed discussion and settling on to move forward with a robust program. And I think that always happens with these type of complex programs. But we do plan to get labeling. We understand, I've been personally involved in many discussions about this. We understand the issues and the positions of the various parties, and we will put something out that people can comment on.
Okay, now I need to ask Mr. Kavanaugh a question, but before I get off of FDA, can you comment on the interchangeability that basically nothing has happened with regard to interchangeability and what the FDA's plans? Yeah, I'm talking to the FDA representative.
Yes, we also plan to put out guidance on interchangeability, draft guidance. That we have discussed interchangeability in our scientific considerations and our Q&A guidances already that are out there. So there's quite a bit of discussion because companies may need to do the scientific work during their development program. But we plan to put out a specific guidance on interchangeability, and we hope to get that out this year as well as a draft.
And finally, Mr. Kavanaugh, I apologize for lack of time here, but I understand where CMS is coming from. You want to have a fair pricing scheme, reimbursement scheme, but biosimilars are different than generics. You understand that, and your agency understands that.
We do.
If you don't allow for some differentiation, since they're more expensive to create, you're not going to create an incentive to do the drug and to do the biosimilar in the first place. Does your agency have any plans to go back and revisit their initial decision on how these are priced?
Thank you for the question. In the regulation we published last year, we did indicate that we would monitor the market closely and that we could do rulemaking in the future if we thought that our payment policy was not as well and is not accomplishing what we're expecting it to. So there is that possibility. I want to return to your point, though. From a clinical perspective, you are right, and CMS knows biosimilars are not the same as generics. However, from a regulatory and market perspective, there are some similarities. These similarities were pointed out in the Senate committee report. They're approved in similar processes in that they refer to an existing product's evidence. So there's multiple, they're going to compete against a reference product and against each other. So from a market and a regulatory perspective, there are similarities. From a clinical therapeutic perspective, there are similarities and differences, and we recognize all that. And we think that translates into the payment policy. We created similarities to how generics are priced, but there are differences as well. We don't have the original reference product in the same code with the same ASP. So there are differences, but we did think the analogy to generics from a payment perspective was reasonable.
My time's expired. Thank the chair for the courtesy.
Chair, thanks, gentlemen, and now recognize the gentleman from Oregon, Mr. Schrader, 5 minutes for questions.
Thank you, Mr. Chairman. I appreciate that. I appreciate the witnesses being here. I'm concerned about the market developing. You've testified, both of you, to that effect, and it seems to be a nascent market that is yet to be mature, and don't want to stifle the competition, and you're struggling with payment policy, trying to figure out what's the best way to encourage good competition, hopefully to build the market, and ultimately, at the end of the day, drive down prices safely, for people. I think, and it's nice that the ACA allows this opportunity, and we were able to get this type of legislation in. Apparently, it's been on the dais, if you will, for a long, long time. So that's good. Dr. Woodcock, you're not in the payment policy business particularly, but could you talk a little bit about interaction between you and CMS in terms of how to interpret the previous generic policies, and since this is not a generic situation, how you came about working with Mr. Kavanaugh or your contemporary on the other side to develop the best payment policy for the biosimilars?
CMS consulted us more on what the biosimilars were, okay, medically and clinically, rather than how they should be paid for, because that's not our expertise. And we interact with their medical staff, who have very clear understanding, I think, of the parameters of how we're analyzing the biosimilarity, what the standards are for biosimilarity, and what the standard is going to be for interchangeability, and the clinical performance that is expected from both of those. And the fact that in some cases we may not include all the indications in a biosimilars label that are in the innovator label for various reasons. So they were aware of all the scientific and clinical parameters in the course of making their decisions.
I guess for Mr. Kavanaugh, you talked a little bit about these modifiers. Could you elaborate? I'm concerned by lumping all the biosimilars together that, if there's adverse reactions and stuff that can happen to any product, for goodness sakes, how you're going to tease that out. Could you elaborate a little bit?
Certainly, and thank you for the question. This is an issue that we were sensitized to through our conversations with the FDA, which is when they're trying to monitor adverse reactions, they often look in large databases of claims to try to figure out which patients received which product, and then look in future claims or in other databases to see whether they had adverse reactions. And they made us sensitive to, if the only indicator of multiple biosimilars was a common number, they would not be able to distinguish between the products, which is important here. So what we did was, working with them, say, well, we'll keep the same billing code, but we'll have a modifier that's specific to each manufacturer, so that when you do query our databases and you see a patient that had an adverse consequence, you'll know which manufacturer's product they got. And so that's how we expect it to work, and we have confidence that it'll work.
Biosimilars are paid for by the government in several different programs, several different venues: Medicaid, Part D, and Part B, apparently. Why do we have different methodologies in each of those? I understand some are intrinsic to the programs themselves, but there's enough variation. Biosimilars are treated, frankly, very differently in the other two programs than they are here, and they're kept individual. No, one biosimilar is not treated the same as another biosimilar. Why have you chosen to do it differently in Part B?
Thank you for that question. The answer is, as you were suggesting, they're different programs, but more importantly than being different programs, there's different statutes behind each of the programs. I have responsibility for both Medicare Part B, but also Part D. The statute that created the payment methodology for biosimilars in Part B is Section 1847A, large A. That is very specific to Part B and has nothing to do with Part D and rebates and payment prices there. So I think it all derives from very different statutes. In an ideal world, you would have harmonization across these, but occasionally we find that there are not consistencies across the programs. And it's not always a bad thing. I think here it created an opportunity for good policy.
I think the policy is being put ahead of the marketplace right now. Maybe down the line, as you alluded to, that might be appropriate. But I'm very worried that with all the differences that we currently have, it's confusing and makes it difficult for drug manufacturers to step up and try and create these wonderful drugs for our citizens. With that, I'll yield back, Mr. Chairman.
Chair, thanks, gentlemen. Now recognize the gentleman from Kentucky, Mr. Guthrie. 5 minutes for questions.
Thank you, thank you, Mr. Chairman. Thank you all both for coming. And I guess my questions are similar to what Mr. Pitts has said and what Mr. Barton asked Mr. Kavanaugh. And it's the payment policy. We're using a similar policy for generic small molecule drugs, as you said, for biosimilars. And you said I think you said to Mr. Barton, there are similar market characteristics you're looking at, and you recognize there are different clinical characteristics that the FDA is concerned with. And that gets to that all biosimilars are tied to not all biosimilars are tied to the same product or the same reference product. And so my question is the concern about the payment policy and the clinical differences that you recognize exist. And we've heard from physicians, we've heard from patient groups, biosimilar manufacturers, a lot of different, at least one insurer, that this policy could lead to a couple of unintended consequences. One would be inappropriate switching between biosimilars, switching to a lower cost that's not the same, and as well as a less vibrant biosimilar market altogether. I believe some of these stakeholder concerns were raised during the process, and wonder why you move forward, and did you consider these warnings?
Thank you for these questions. We did consider these because we received these in the public comment process, and we thought very deeply about each of those issues. First of all, the concern about a less vibrant market, as I mentioned some statistics earlier, but in Part B, the top 6 drugs that we spend money on are all biologics. We spend over $1 billion on each of them. I think that alone creates the opportunity for a very vibrant market in biosimilars, and I think that's why you're seeing the level of interest that the FDA is seeing in approving products. As far as inappropriate switching, first and foremost, I think physicians do not order biologics or other drug products by billing code. And Dr. Woodcock is a physician and can extrapolate on that. And similarly, pharmacists do not derive what switchings they're allowed to do based on billing codes. There are other conventions in place. So we thought long and hard about that concern. We talked to our pharmacists, we talked to our physicians, we talked to the FDA, and thought that though we had heard that publicly, that was not a concern.
Okay, so the FDA isn't concerned that could come to pass? The two things that I just mentioned could happen?
Well, again, what we are seeing would be that a biosimilar would be either written by a physician by the name, right? Or it would be switched, if it were interchangeable, it could be switched at the pharmacy level based on our purple book where we said it was interchangeable. Right. So those are the processes we see, and with the e-prescribing and so forth, there are menus that come up, and those have to do with the name of the product. Mm-hmm. Now, I don't know. I've been out of practice too long to know how this reimbursement loop, which has really gotten very complex recently, how that would impinge. But that's how the ordering would be done. All right.
Okay. Well, thanks. And I have another question. So, Dr. Kavanaugh, I noticed that you treat biosimilars as a multi-sourced product for the purpose of payment. However, they're treated as a single source for the purpose of the Medicaid rebate. Can you explain the contradiction, or apparent contradiction, I guess?
Certainly. It all derives from these being different programs and different statutes that authorize payment. I'm on the Medicare side of CMS, so I'm not as conversant in the Medicaid statute. But as I mentioned earlier, the statute that created the authority for payment for biosimilars is very specific to Part B drugs. And so it by definition would not apply to Medicaid or Part D. And so I think any differences derive from the statutory differences.
It's kind of a contradiction, though, to have multi-source one way and single the other when something needs to be corrected or fixed, or maybe it needs to be fixed statutorily, or...
They are not consistent, but again, the statutory authorities are different.
Okay, I'll check. Well, Mr. Chairman, I yield back the balance of my time.
Thanks, gentlemen. Now recognize the gentlelady from Illinois, Ms. Schakowsky. 5 minutes for questions.
It's really exciting that in recent years that we've seen such breakthroughs in drugs entering the market that create such hope for treatment or cure for illnesses of millions of Americans. But the cost of these drugs, I want to focus on that because I think it's simply unaffordable for far too many people. In 2013, the average cost of specialty drugs was over $53,000, an increase of 193% from 2005. And this average drug cost is greater than the median U.S. household income, more than double the median income for Medicaid beneficiaries, and nearly time and a half as much as the average Social Security retirement benefit. And a recent Kaiser poll found that 73% of Americans believe the cost of prescription drugs is just simply unreasonable. And so it's clear that we need additional federal authorities to combat this growing problem, and that's why I introduced the Medicare Fair Drug Pricing Act, which would require HHS to negotiate the price of biologics and sole source drugs covered by Medicare Part D, one possible solution. The high drug costs are a problem for both Medicare Part D and Part B, as Mr. Kavanaugh, you well know. In 2010, biologics accounted for $8.3 billion, or nearly 43% of all Part B drug spending, and that number is likely to rise. High-cost biologics are continuing to enter the market. I'm happy that the biologics are entering the market. Medicare beneficiaries are also struggling to afford the co-pays that are associated with these drug prices. In addition to enhancing HHS's ability to control drug costs, we need to ensure that we have a robust marketplace for biosimilars. Several studies estimate the projected savings from the approval of biosimilars for current high-cost biologics to be anywhere from $44 billion to $250 billion over 10 years. We have an opportunity here to expand access to life-saving drugs and lower costs for patients. Dr. Woodcock, as a rheumatologist, you were talking about the exciting new drugs, but you were also talking about the cost. Are you aware of people who have been absolutely turned down? In other words, walking away from the pharmacy? I've talked to some pharmacists about people who do walk away.
Yes, I am aware of that, and I'm aware of what my colleagues currently go through now to try to get their patients drugs that are indicated for the condition by FDA.
It's a huge concern. Dr. Kavanaugh, how have biologics, I know you talked a bit about that, contributed to the increase in Part B spending on drugs, Medicare Part B?
So Part B, like the rest of the drug world, has been going up faster than the rest of the healthcare economy. It's put a strain on the Medicare program. The biologics in Part B are the vast majority of the spending. I mentioned that the top 6 drugs in total spending, each individually is over $1 billion, and they're all biologics. And so the agency shares your concern, and I think you've expressed the right balance, which is, as Dr. Woodcock said, therapeutically, some of these are terrific products, and they've changed lives and improved lives, and we don't want to lose that at all. But we want to balance it with making sure everybody has access, and that comes through affordability.
You know, I just want to say, in some ways, I feel like the feelings of an individual, that it's almost worse and more painful to know that there actually is a treatment or a cure out there that they can't afford than thinking there isn't one. That it's right there, I can see it, I can feel it, I know it would help me, but I simply can't afford to get that. And I think that we have to address that problem. What are the solutions so that Part B, Part D is not going to go bankrupt, that insurance companies will be able to afford to provide the help that people are going to get? What are we going to do? Either one, both.
Well, again, I would just want to reiterate that we share your concerns. As you may know, last year, the Secretary Burwell and Administrator Slavitt convened a listening session. So we've been hearing from patients, from pharmaceutical manufacturers, from pharmacies and others about ideas they have, and we're hopeful that some of those ideas can come to fruition. I don't know that the silver bullet's been discovered yet, but I think there's a conversation going on that could produce something that we could all support and achieve that balance that we're looking for between affordability but still having access to these life-changing therapies.
Well, I know that members want to be part of that conversation, so I appreciate that. I know you recognize the problem, and I yield back.
Chair, thanks, gentlelady. Now I recognize the gentleman from Kentucky, Mr. Whitfield, 5 minutes for question.
Thank you, Mr. Chairman, and thank both of you for being with us today. We all recognize the important responsibility that you have, both of you. And I'm going to touch on something a little bit different. Certainly it is my understanding that biosimilars are many times more complicated to consistently produce than generic drugs. But a couple of days ago, I was reading an article, and there have been many articles about drug shortages. And the American Society of Health System Pharmacists currently lists inadequate supplies of more than 150 drugs and therapeutics for reasons ranging from manufacturing problems to federal safety crackdowns to drug makers abandoning low-profit products. And as a result of that, doctors and hospitals are doing rationing. And sometimes they make decisions about who gets a drug based on weight, sometimes on the age of the patient. And I was also, in this same article, it talks about that in a survey of cancer doctors, 83% of them said over the last 6 months that they they were unable to provide the preferred chemotherapy agent at least once during the last 6 months, and that a third of them said they had to delay treatment and make the difficult choice of which patient they're going to give it to. So rationing these shortages. So both of you are well respected in your field. Would you just make a brief comment about this shortage problem and whether or not you all are working with manufacturers, because biosimilars is even more complicated than generics?
Clearly, this situation is unacceptable, that people with cancer or others would not be able to access life-saving treatment. We've had a very robust shortage program for many years where we try to anticipate and respond. But I think the fundamental problem is the number of drugs that have a single source, or perhaps maybe only one competitor. If you look at this chart, this shows all the drugs, and I can put this in the record, Mr. Chairman, and you can see that for 99 drugs that we have, where there's only one generic competitor. All right, so there's only 2 on the market. And then we have another chart here that shows for 125 innovator drugs that have no patent or exclusivity protection, there's no generics. And this isn't a result of FDA's backlog or anything. Nobody sent in any applications. So there's a problem in the market that other entrants don't come in. And sometimes we get generic entrants and they don't market the drug. And so then if the single manufacturer has a problem or they decide to raise the price greatly, there's no competition there. Now, our generic user fee program is accelerating the approval of generics overall to a 10-month clock for review. So that will help somewhat with new entrants. But in the meantime, it may be that no one is interested in entering that market, even though it's a critical shortage of a life-saving drug. And I can't tell you why that is. I don't understand those factors, but that's the reality that we're facing.
I would concur with everything Dr. Woodcock said and just add that if folks believe that there are CMS policies that are contributing to shortages, I would like to know, and I'd like to think about what we could do to be part of the solution. I mean, the reason many of us came to work at CMS is to help our beneficiaries, and if they're being denied because of market failure or because of policies, we would like to be part of that solution. So I appreciate you raising the issue. It is of concern to us.
Thank you. I yield back my time.
Chair, thanks, gentlemen. Now recognize gentleman Mr. Butterfield, 5 minutes for questions.
Thank you so much, Mr. Chairman. Mr. Chairman, let me first talk about my district and then build out from there. The health disparities that face African American communities in my district in eastern North Carolina and across the country are absolutely alarming. The FDA knows that. Anyone who watches this knows it for sure. We could just talk endlessly about the chilling statistics that show Black Americans are more susceptible to serious illnesses than any other demographic. Serious diseases such as HIV and diabetes and cancer more frequently occur in African American communities. Rare diseases like sickle cell anemia occur more often in African Americans. The sooner that affordable, safe, and reliable treatments are discovered, the better we're all going to be. Like most, I see the potential that biosimilars can have in combating health disparities. The Affordable Care Act is helping to make that possibility a reality. And so the Biologics Price Competition and Innovation Act, which was part of the ACA, has helped set up a framework to enable the development of new biosimilar drugs. Since 2010, the FDA has worked diligently to implement the program. Biosimilars are complex, and we've heard that testimony today. And I agree with Dr. Woodcock that their regulation must be bulletproof. It is critical, therefore, that the public can depend on approved biosimilars and that we encourage the development of new treatments. And so it is my hope that the creation of new biosimilars can make safe treatments more affordable for those in need. Thank both of the witnesses for their testimony today. Dr. Woodcock, it's my understanding that current FDA guidance allows biosimilar applicants to extrapolate efficacy information based on the reference product. I don't fully understand that, but I'm sure that you do. If you would expand on that, please.
Well, basically, the biosimilar pathway itself is an extrapolation, all right? What is done, it's an abbreviated pathway. So if you can show your product is biosimilar through various means that we've established to the reference product, then you may be able to, depending on what you've shown, have a label that looks exactly like the innovator label, or you may only have some of the indications depending on what you have shown. So there are two kinds of extrapolations people are talking about. One is the basic abbreviated pathway, which means we find the evidence that's submitted by the biosimilar and we say, yes, this means that you have the same properties as an innovator drug. And then many of the brand drugs have multiple indications. For example, next week it would be ulcerative colitis, Crohn's disease, and rheumatoid arthritis, all right? Those are different diseases. And so what many people are talking about is extrapolation across from one disease to another. What amount of data that we need to grant all those indications is a scientific matter and may be of some dispute, obviously, because there's a lot at stake there. But I will tell you, we're not going to approve biosimilar drugs that we don't think have the same performance as the innovator. That is what we are going to do. They're going to, if a patient is started on a biosimilar, they should expect the same results as if they'd start on a brand drug.
Now, there are a lot of stakeholders. There are a lot of people who have an interest in this subject. I'm beginning to appreciate that, and I see the room full today, and I'm sure there are a lot of people here who are listening very carefully. Are there concerns that stakeholder groups have, and are there any concerns that have been shared about extrapolating clinical safety and efficacy data for biosimilars which treat special populations, including children or certain fields, including rheumatology?
Certainly, people have concerns still about generics, and there are certain groups, such as the neurology community, that still isn't convinced they should do generic substitution. Recently, we have sponsored studies to show that there's no outcome difference between a generic and an innovator drug for seizures. So there's going to be concern, and there's going to be ongoing concern, regardless of what we do. But people, right now, we do extrapolate often for regular drugs, whatever, biologics, or For the brand drug, we may extrapolate to children based on dosing information if the disease is similar enough, rather than subjecting children to randomized clinical trials. If we have enough scientific data, we will extrapolate after finding out what the right dose, what the equivalent doses are in children of different ages.
Thank you. I yield back, Mr. Chairman.
Chair, thanks, gentlemen. Now I recognize the gentleman from Illinois, Mr. Shimkus, 5 minutes of question.
Thank you, Mr. Chairman. I know we're getting close to calling a vote, but I want to first of all address Mr. Kavanaugh. And I appreciate your answers, but I don't think they're totally accurate, because I think under the law, and especially the report language of the bill passed, the report language and the congressional intent was that there would be separate billing codes to reimburse at the ASP of biosimilars. So, I mean, your comment saying, well, I can't do this because of statutory intent is, we feel, is inaccurate. So I'm going to move most of my comments to there, and I hope you would take that back, because we think you do have the authority to do that. And the other thing, just as a comment, listening to testimony, the biosimilars, the efficacy and the ability, the cost benefit, the return on investment, Dr. Woodcock, as you mentioned earlier, as a rheumatologist, and wellness versus treatment, there's a great return on that investment that somehow has to be put into this pricing decision, right? So, but I want to get to a couple questions in this whole process. Let me start, Dr. Woodcock. I understand that the FDA has not provided details on specifics of interchangeable products. Is it possible that FDA might approve an interchangeable product without first issuing guidance or interchangeability?
Yes, it is. As I interchanged with Mr. Barton, the statute allows us to execute the statute without guidance, is my understanding.
Under current law, a new biological product can be brought to market either by being approved as a new drug or being licensed as a biological product. How, if at all, does a manufacturer's decision to use one pathway or another affect pre-market review of a product?
The body of evidence that is submitted for a biological license application, a standalone, right, is different than the body of evidence that is submitted for a biosimilar.
So how?
Okay, a biological.
So what's the answer?
I'm sorry. A biological product standalone must demonstrate freestanding safety and efficacy of that product. All right. A biosimilar must demonstrate biosimilarity to a reference listed, already approved biological product. Those are conceptually, fundamentally two different things.
So really the question is, if they choose one pathway or the other. I mean, right now, how are they making the decision which pathway to choose, or how can they?
We have around.
Or let me just go to the next question, because they're all kind of in line. What about the post-market obligations if they choose one pathway or another?
It's unlikely that a biosimilar product would not have additional questions that would be post-market commitments, but they have the same safety surveillance requirements as other marketed products.
Okay, let me just go to another one, then I'll tell you why I'm asking these specific questions. Does the FDA consider the Purple Book to be part of a biological products labeling?
Does it consider what?
Do you consider the Purple Book to be a part of the biological products labeling?
No.
Okay, so these are all questions asked by U.S. senators in your testimony in November, which they still have, as they've asked me, to restate these questions. You know why? Because y'all haven't responded to their questions in writing.
Oh, okay. Well, we certainly will do that.
And the point being is there is great confusion out there in the healthcare sector on how we're going to move forward. And this hearing is going to have follow-up questions. And they just need to be answered. And so, again, all these are follow-up, and there was a lot more. I've got 4 or 5 pages of them from bipartisan questions that need to be addressed so we can help then figure. And that's actually the same questions that you're being asked by the stakeholders. And so I would ask you to respond timely to the questions posed by my colleagues, and I yield back my time, Mr. Chairman.
Chair, thanks, gentlemen. Now recognizes gentleman, Mr. Cardenas, 5 minutes for questions.
Thank you very much, Mr. Chairman. Thank you, Dr. Woodcock and Deputy Administrator Kavanaugh, for joining us today. Dr. Woodcock, under BPCIA, interchangeable biologic products must demonstrate that they can be expected to produce the same clinical result as the reference product in any given patient. A biosimilar determined to be interchangeable can be substituted. So therefore, my question is, will you discuss generally the types of questions the agency is thinking through as they are considering guidance to industry in this space?
Issue has been before us, even before the statute was passed, which is one of the differences of biologics from most generics is something called immunogenicity. In other words, the ability to stimulate an immune response in a patient, a reaction. And this can be insignificant, or it can cause serious problems. And one of the concerns is, under a scenario of interchangeability, what we see in the generics world, people get all different kind of products, generics. They switch at the pharmacy based on their plan. And the concern is, if you're switching back and forth, could you set up an immune response that would be negative to the person? And how you have to address that concern for interchangeability is contingent on a number of factors. A number of these drugs are not, biologic drugs are not that immunogenic. And some of them they are, but the consequences have not been severe. All right, others, the consequences could be catastrophic. So we take all those factors in talking to companies about how much evidence they have to show that switching people back and forth wouldn't cause terrible harm. And the problem we have is the science isn't far enough advanced for us to predict this from, say, test tube experiments. We have to look in people because we don't understand the immune system well enough. So there has to be some human testing of switching ordinarily to give it confidence that, in fact, if you switch the people back and forth, they're not going to have some unprecedented problem.
Thank you. This question is to Deputy Administrator Kavanaugh. I'd like to reiterate the concerns voiced by my colleagues on both sides of the aisle and the final rule for the physician fee schedule, which places biosimilars that reference the same biologic into single HCPCS code. Biosimilars are not generic drugs because they're not the same copies of one another, and I appreciate how hard you and your colleagues at CMS are working to create a robust biosimilars market. However, because biosimilars are so complex, I fear that this may discourage manufacturers from entering the biosimilars market. How do you feel about those dynamics?
So thank you for the question. I think it's important to recognize a couple things. As I said, the important therapeutic differences, which the FDA has educated us about, and we recognize them, but there are also regulatory and marketplace similarities. And in fact, the congressional history here shows that the approval processes were mirrored or paralleled off of generic approval processes. We expect them to work in the marketplace much like generics, in that there'll be a low-cost alternative to a higher-cost innovator product. And for that reason, and also for statutory reasons, the statute said that for products where there's multiple products under the same billing code, they should have the ASP averaged. I want to emphasize why we think this is a successful policy. One, to Congress's credit, from the physician perspective, when they're ordering the drug, Congress created a payment where they're still getting the 6% markup from the innovator product. So the physician is not invested in a higher cost product. They're made whole either way, and I think that was a terrific policy that Congress made. But secondly, they're going to choose the therapeutically successful product at a fair price, and we'll have these biosimilar products competing on price with each other. So the last thing I would say is, even though they're using a methodology similar to generics, that doesn't mean the resulting price will be similar to generics. The biosimilar companies set their own average sales price, so they can set it at a market-bearing price that reflects their costs, whether it's research or other input costs. So I don't think the fact that they're the same methodology means you'll end up with the same price.
Thank you. With my 5 seconds, I just want to remind the American public that what we're talking about here cannot be put in one page. So I want to thank my colleagues and also the process for understanding that laws aren't necessarily 1 or 2 paragraphs. These are very important issues, and protection of the public is very important to our country. Thank you so much, Mr. Chairman.
Chair, thanks, gentlemen. We are voting on the floor, so we'll continue as long as we can. Chair recognizes Mr. Collins, 5 minutes for questions.
I want to thank the chairman, and I know we're now trying to hold the votes down, so thank you for letting us cut into this just a bit. Thank both the witnesses, Dr. Woodcock, Mr. Kavanaugh, for coming. I think, you know, what I've heard is some 30,000-foot cliff note discussions on biosimilars, generics, biologics, et cetera. And Dr. Woodcock, as you're sitting there, I know you must have some level of frustration because we are under time constraints to get the point out. And so in my time, I think we've pretty much established a generic is, for all practical purposes, 99.999% the same as the brand name. It's a compound, it's usually a pill, it's the same, and therefore doctors prescribe that. But Dr. Woodcock, you know, in what testimony you've given and thinking about the differences in a biologic and a small molecule, which are 2 different worlds, and a biosimilar which will never, ever, ever be the same. And while you've explained, and I think it's true, the FDA's emphasis is safety and efficacy. And I guess you'd say safety, 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 safety. And then we got to know it works as well, but safety is always first. You know, in 2 or 3 minutes, for the purpose of this committee educationally, what would you like to add as far as how the FDA is looking at, and maybe even explain to the committee the basic difference in why a biosimilar will never be a generic, and even the manufacturing process of a biologic, the sterility process, or, you know, give us 2 or 3 minutes of education, which I think would be helpful to this committee, having heard already some of the questions.
Well, the biologics are very large molecules. In other words, it would be like maybe a little house compared to the Empire State Building as far as the comparative size of the regular drug to a biologic. And if you just think about the brand biologics, most of them, they're not exactly the same from batch to batch. I know that's very disappointing, but they're made by cells usually.
So it's the manufacturing process is unique.
Yeah, they're biosynthesized by cells, and those cells are subject to conditions we don't understand very well fully or can't fully control. And so they're slightly different from batch to batch to batch. Our job in regulating them is to make sure that those variabilities in the brand product I'm still talking about don't affect safety, 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 or effectiveness, okay? So that they stay in a band where from the clinic, if you're a doctor treating patients, it doesn't make any difference. But it isn't like the small molecule where every tablet, we know exactly what's in there.
And to interrupt, isn't it also true that in the intellectual property protection, et cetera, a manufacturer is not required to tell the world exactly how they're making it?
Never, and that's true with the generics as well.
Well, and that's what I think some people miss. You have to put enough information in your intellectual property to say, I can replicate it. But you don't, a manufacturer is going to protect his price point. I mean,
well, it is considered trade secret.
Right, and it will always be trade secret. So when a generic or a biosimilar comes out, they don't know the 16 steps
That's correct.
that the brand name is doing to make that product.
Right.
And hence, in the case of a biosimilar, it can never be the same.
Well, what they do, and what we found, okay, is for generics does this too. They have to buy the reference product on the market and reverse engineer it, and then develop a process of their own that'll replicate that, avoiding any patents that might be pre-existing that, you know, may be on process and so forth.
Well, and it's just like reverse engineering anything. You don't know and don't have the prints of the original company to know the tolerances
That's
for
correct.
every item and how they interact. So I think, you know, in defense of the FDA and what they're doing in the safety, 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 but also looking at efficacy, The folks making a biosimilar don't have the prints. They don't have the process. They're trying to reverse engineer it, and yet the FDA has to make sure in reverse engineering it, safety's not compromised, efficacy is there. And that's why it is, I mean, you've got a very, very, very difficult job in bringing biosimilars to market, knowing that the person making it doesn't have the benefit of the drawings, the process. They're guessing, they're reverse engineering, they're hoping they get it right, and you have to make sure at the end of the day it's safe and the efficacy is there. So.
And also what we found, to your point, it's a very good point, what we found as we work with these companies, they're going to have to get lots of the reference drug. Generics usually
The variation.
Because they have to be within the variation.
That's
if
right.
you just pick a small sample, it might be outliers. And
My time's up. I thank you for that. I think the education piece is very valuable.
Thank you. I'm
Dr.
sorry to rush you. We have 8 minutes left, so we're going to have to try to hurry as much as possible. Dr. Bashan, you're recognized 5 minutes.
Yeah, Mr. Chairman, I'll be brief and just make a comment and maybe a brief question. I'm glad that you're both here. Thank you very much for your work. That said, Mr. Kavanaugh, this is kind of directed at CMS. It appears to me as a physician, and I was a practicing cardiovascular surgeon, that CMS has become the rate-limiting step in getting innovative products to the marketplace and to patients. A brief examples, a treatment for glioblastoma for brain tumors, for example, a bionic prosthetic to benefit veterans and others. And it also seems to me that frequently on reimbursement decisions that comments and recommendations of experts outside of CMS have been ignored. Unfortunately, in my view, decisions are being based on financial reasons, not based on medical benefit of the products. I'm talking about products that have been approved by the FDA and other organizations around the world and subsequently are also reimbursed frequently by the private sector insurers and then are not reimbursed by CMS, or it's been drug out so long that some of the innovative companies have almost gone bankrupt because CMS hasn't approved their payment. So the question I have is it the role of CMS or the FDA to determine the safety and efficacy of medical products, including biosimilars?
To me, sir?
Yeah.
No, it's the role of the FDA to determine.
Okay, so once these are proven to be safe and show efficacy for patients, why is frequently CMS dragging its feet on reimbursing it? What's the reason?
Is the question specific to biosimilars or broad?
Yeah, broadly.
The reason, well, first of all, as I said, on the first biosimilar, we acted very quickly, and in fact, we had a billing code and coverage guidance before it was actually even marketed. You raised other examples, though, that are broader than biosimilars.
I was just throwing those out there. Let me just tell you, as a physician, many people talk to me about medical issues, right?
Yeah.
Because I was a practicing physician. And it's not just I mean, I've literally heard from hundreds of people frustrated with CMS because there have been, and these are coming from patients, from physicians, from companies everywhere, telling me that these products are approved by the FDA, they're frequently reimbursed by the private sector, and that CMS has either decided to not reimburse them or drug their feet, or put up a price that is not competitive to, for the production and maintenance of a company or the product to be actually on the marketplace at all. And it's very frustrating for me as a physician to know that there are products out there to benefit patients. And I know you have a tough job. I'm just on my soapbox a little bit here. But I just don't get it, because if things are approved by the FDA, they're frequently approved by the same organizations in the European Union and around the world. And these products are not available to people in the United States because not that they're not proven to be effective and safe, but Medicare hasn't decided how they're going to pay for it. And so if you're not making decision on safety and efficacy, how can you not decide not to pay for it?
Sure. I think it's a terrific question. It allows me to talk about the Medicare process. FDA approved safety and efficacy. When it comes to the Medicare, there's two standards they need to meet, any product or service. One is it has to meet in one of the statutorily defined benefit categories. So the statute has to say this is something, this falls into a category that applies to Medicare coverage.
I'm going to briefly interrupt you. That's already been determined by the FDA. There's been clinical studies that they've gotten that have shown efficacy, that have shown benefit to patients. So that seems like reinventing the wheel to me.
With all due respect, the benefit category is not about safety and efficacy. The Medicare statute specifies the covered services and benefits. And what I'm saying is, no matter how safe and effective FDA finds it, it can only come into Medicare if it meets the statutory definition of something that Medicare covers. And after it makes past that criteria, the secondary criteria is it reasonable and necessary for a Medicare
Understood.
coverage?
Since I only have 10 seconds, I just want to say that, in my view, every product that's approved by the FDA should be available to America's seniors, and the limiting factor should not be the ability of CMS to stonewall and not pay for it. And I'm just telling you, it's a very frustrating situation. I yield back.
Chair, thanks, gentlemen. There are 3 minutes left on the floor clock. Chair recognizes Ms. Elmers for questioning.
Thank you, Mr. Chairman, and I will be very brief. I want to thank the panel. Thank you, Dr. Woodcock, for being here again, and Mr. Kavanaugh. I actually just have 2 letters that I would like to submit and ask unanimous consent to do so.
Without objection, so ordered.
One is actually from our Doctors Caucus. 12 members of the Doctors Caucus submitted a letter on December 21st to the acting secretary, Commissioner Ostroff, and we have not yet received a response to those questions. And so, Dr. Woodcock, we will be submitting questions for you, and I know that this is an interim, but we would look forward to some of the answers. You both have answered many of the questions that we've already had. Now, the other letter that we have that I'd like to submit under unanimous consent is from the Coalition of State Rheumatology Organizations. This is a letter that I would like to be
Without objection, so ordered.
Thank you very much, and again, thank you to our panel. This is a very, very important issue to all of us, and I know that we all agree that we need to get to the bottom of this so that we can help those folks out there that need the help. Thank you.
Chair thanks the gentlelady. That concludes the questions that we have here. We have follow-up questions. We'll submit to those to you in writing. We ask that you please respond promptly. Members have 10 business days to submit questions for the record, so members should submit their questions by the close of business on Thursday, February 18th. Very important hearing. Thank you very much for your testimony today. Without objection, the subcommittee is adjourned.